My name is Jonathan Lau, and this is a pre-recorded talk for the Organization for Human Brain Mapping meeting, specifically a roundtable session on in vivo thalamic nuclei imaging segmentation and applications. I want to thank the organizers for the opportunity to contribute to this, and I'm looking forward to interacting with them, as well as the co-speakers in this session. Specifically, I've been given the task of talking about imaging of the thalamus from a clinical perspective, in my case as a practicing neurosurgeon. I'll start off with some clinical context, and in my practice as a surgeon practicing functional neurosurgery, one of the most common procedures I perform that requires improved thalamic imaging is a deep brain stimulation surgery. This specific procedure involves implanting electrodes deep into the brain, about 1 to 2 millimeters in diameter, about 7 to 10 centimeters deep into the brain, into small targets. And then what we do at that point, in this case, I've given the cartoon example of the subthalamic nucleus. I apply focal electrical stimulation to a specific area to have a positive impact on specific patient symptoms. Now, classically speaking, because these structures are quite small, we aren't able to see them. We weren't able to see them with conventional imaging, so we would use a histological atlas, here like the Shelton brand atlas, and provide that mapping into the space of the individual patient. And there are numerous other targets in the basal ganglia and thalamus, including the globus pallidus internus, the ventral intermediate nucleus, and the caudal zona incerta. Now, what is standard still to this day is performing a preoperative MRI in the weeks to days before surgery, then planning the procedure in the days before surgery, and then on the day of surgery, typically providing a scalp block and then getting a CT with the patient in a frame. Now, due to some uncertainty with regards to the location of the target, one of the tried and true methods for ensuring that we are in the right spot is to perform these procedures awake, or certainly with some type of intraoperative data that allows us to be sure that we have reached the target that we expect to. Now, with this context in mind, I'll just split off the rest of my talk into two sub-themes, one about spatial correspondence and the second about ultra-high field MRI. Starting with spatial correspondence, so we're very interested certainly in neuroimaging in this problem of establishing correspondence. We have a subject scan and a template scan, and we can provide a way of mapping between these two spaces. Now, certainly we all understand here that parameters can impact the quality of template to subject registration. Here is an example of a patient scan and being panned between that and a high quality 7T template. And here we see the ventricles are well aligned, and there's certainly a suggestion that we have a good mapping between those spaces. Now, if we go to the right-hand side here, we can see that parameters have a significant impact on the quality of this template to subject registration. And these are just two examples of just adjusting those parameters. And we can see this shift in space of the subthalamic nucleus among other structures that is certainly significant, on the order of close to 10 millimeters. And that would certainly impact any sort of, would render these type of procedures are not usable from a DBS planning perspective if we had this degree of misalignment. And so there's certainly a need for improved ways in which we can assess the quality of these template to subject registrations. So how have we traditionally done this in our field? So again, this cartoon example of the subject and template. certainly the literature over the last decade or more has mostly leaned on region of interest-based assessment. So here is a token example of a mid-sagittal segmentation of the corpus callosum. And if we look at the mapping between these two, that can certainly provide one measure of registration quality. Another is traditionally used, and that is point-based assessment, including these point landmarks. And certainly when we bring the subject into template space or vice versa, then we can compute these metrics. If we're looking at segmentations and we look at voxel overlap, a measure like the Jacquard index, such as the intercept over the union, or with point-based landmarks that we can use registration error, which is very intuitive metric, as it's just the Euclidean distance between the two. And I will emphasize as part of this talk today that we have been underusing the registration error metric, which is a simpler metric to me, but because of, for a number of different reasons, partly due to convenience, we have found that regions of interest is our go-to because they are available with most of our common neuroimaging pipelines. So it was in this context that we created the anatomical fiducials protocol, what we are calling AFIDS, and our initial publication was in Human Brain Mapping in 2019. And on the top right here, we're cycling through the 32 landmarks that we propose as being quite reliably and accurately placed within 1 to 2 millimeters. We created this protocol initially manually. It takes about 25 to 30 minutes for a trained rater to place these on an individual subject, and they place them using a 3D slicer, which is an open source software. And then we are able to quantify accuracy and reliability. We've been able to establish the utility of this protocol as a tool for identifying misregistrations. And it was really important for us to build this in a completely open way and as a tool for education. And so you can find some of this information for the initial publication, and as well as on GitHub. And here's an example of why we think it's helpful. So here we have those points in black overlaid, and you can see how they are related to some of the subcortical structures. And these are subcortical segmentations available through FreeSurfer for the pallidum, striatum, and thalamus. When we look at voxel overlap, looking at that template to subject registration, you can see that on the histogram that most of the measures are quite acceptable. If we consider 0.75 usually as being a good metric of how well registered two structures are. And there are very few outliers that suggest a misregistration of any of these regions of interest. If you look at these point landmarks again, we have perhaps more useful metric that demonstrates a long tail. So we can see that even though many of these structures are considered to be well registered based on a voxel overlap measure alone, then when we look at registration error and we consider perhaps 2 millimeters being what would be significant, that would certainly be significant clinically if we're talking about a brain target, then there's a long tail of misregistrations. Looking at these on the individual ROI scale, so if we're focusing first on the thalamus here, we can see that although the thalamus generally was quite well registered across all our 30 subjects as part of this original study, that even when the thalamus is well registered, there are many points that are misregistered that qualify as being clinically significant in terms of the registration error. And this is also matched for the other structures, the pallidum and striatum. And this is certainly impetus. So this is for two reasons I stress that we should start thinking in terms of millimeters if we want to consider the use of these tools for these more extreme clinical indications like stereotactic targeting. but it also provides us impetus to work towards other ways of getting high quality imaging, such as ultra high field MRI. And so here I have a 7T MRI for DBS in a standard coronal plane. As you go from standard field to ultra high field, you get an at least linear increase in the signal, which represents a 2 to 3-fold increase in the total signal. And this can be exploited in different ways. So if you look and zoom into the subcortical region, we can see a much more clear delineation of our structures, such as the subthalamic nucleus, as separate from other structures in the subcortical region. Certainly one of the concerns going to higher field has been this issue of distortion, and our group, among others, have been able to characterize these and find that they tend to be at the air tissue interfaces. In most of the core areas and close to the isocenter of the magnet, and where the thalamus and other subcortical structures are, the distortions are not significant. We've also looked at the feasibility of getting patients into the 7T MRI, and we've scanned over 100 subjects at our center prior to stereotactic surgery for different reasons. And while there have been some transient dizziness and vertigo, it has overall been well tolerated, and even 4 out of 5 patients who were claustrophobic were able to complete scanning. And this is an example where we've linked in 7T MRI into our clinical workflow. And you can see the location of the contacts on the CT, and it also certainly makes planning much easier when we have this amount of detail. We also found it helpful to be able to visualize new structures that had not previously been identified at in vivo, including the zona incerta just below the thalamus. And this is an example of using MP2 RAGE for this purpose. And we can make out the zona incerta in blue as separate from the surrounding cerebellothalamic tract. And these are as far as we understand it, the first in vivo reconstructions of the zona incerta and surrounding structures. And here we're showing this on the individual scale, and how it is important to consider each person independently. As you can see, a wide range of morphological variability. But what is quite interesting is we generally looking at this quantitatively using T1 metrics, that we can see a clear delineation between the zona incerta signal as separate from the surrounding white matter tracts. And while the values were not exactly the same going in our replication data set from Maastricht, which Roy Haast has been involved in, there's certainly the same trends were there. And this is a plug to Roy's paper looking at these differences in T1 intersite T1 reproducibility at 7T. In summary, I just wanted to highlight 2 potential avenues in which it's useful to consider some sort of the clinical perspective. The problem of spatial correspondence, I think there's been an overemphasis on voxel overlap as the main or metric that has been used to establish whether a segmentation or structure has been identified accurately. And second of all, you go into ultra high field MRI, where we can move towards individualized imaging. This is a plug to my lab, the Ames lab, and some of the work we've been doing. I didn't have a chance to touch on the work we've been doing on connectomics of the subcortex, but I'd be happy to connect outside of this meeting to discuss this. My contact information is below, and this certainly wouldn't be possible without a great team that I have at Western, as well as a great set of collaborators. Thanks for your attention.